me a great honor to introduce Professor Zobair Younossi. He is the chairman of the Department of Medicine in Innova Fairfax Hospital in Virginia, in USA. He's a very well-known authority in liver disease, fatty liver disease, and many others, and I think you've heard him talk yesterday. He's going to be talking to us about treatment of genotype 1 with DAAs, hoping that the lecture you just heard is the last lecture you'll ever hear about interferon in your life. Thank you, Professor Younossi.
Thank you very much again for the invitation to this wonderful meeting. Maybe I can get my slides up. All right. So my task is to follow Dr. Colombo about interferon-free regimens and if there are any role for interferon-containing regimens still for genotype 1 and 4. And what I like to do is to go back to what I introduced yesterday, that when you decide to treat a patient, you really need to choose the regimen that delivers the best value to the patient. So what is value? Value is an equation that will have three components: outcome, quality, and cost. That's how we define outcome. And in hepatitis C, the best outcome that we know is SVR. The best quality is quality of life, the indicator of quality, and costs are things like cost per SVR or cost effectiveness. Of course, the most important issue now is access and finally acceptance of the regimen by the patient and by the society and the governments. And of course, these two are related to the issues of adherence. I showed this slide yesterday, and this is really the comprehensive goal of achieving the best outcome for the patients in terms of clinical, PRO, and economic outcomes, which are surrogates of survival, patient experience, and resource utilization. So if you achieve SVR, and you saw the slide yesterday as well, then you will actually improve survival, you will improve patient-reported outcome, and you will also improve economic outcomes. So what I will do in the next 18 minutes or so is to examine the evidence in terms of interferon and interferon-free regimens. What is the data supporting it? And I'll do this in terms of looking at efficacy. Then I'll go and also show you data on effectiveness, the impact on PRO, and then finally impact on economic and outcome of every one of these regimens. So these are the regimens that are available. So this is what we have right now in 2016. And shortly, as you've heard from Mark Sulkowski and Dr. Massimo Colombo, these are the regimens that are pan-genotypic, the next version that probably will be available in the United States shortly. And then we're looking forward to the triple combinations that are coming up that probably will shorten the duration from what we have right now from 12 weeks to 6 weeks, and I'll show you some preliminary data as well. So let's look at sort of historical data on interferon and ribavirin. You saw this. Response rate in genotype 1 patients using PEG interferon and ribavirin is about 40–45%, and genotype 4 probably about the same, around 50%. Effectiveness suggests that there is a 50% reduction in SVR when you go out to the community. And I showed this data yesterday that when you have interferon, PROs take a dive. There's a severe decline in patient-reported outcomes. When you look at cost, although cost per pill may be okay, but cost of the regimen, primarily due to side effect management, could be up to over $200,000 per cure, $200,000 per cure for these regimens. So how about the first generation DAAs? And you saw some of this from Massimo just a minute ago. So the overall efficacy in randomized clinical trials of the two regimens, Alfaisaliah and Zobair, was somewhere around 65–70%. Now when you look at effectiveness, and CUPIC is really a very good sort of example, again, you take a pretty big sort of reduction in effectiveness up to 27% in some patient population due to primarily to the severe side effects, including death. When you look at cost per cure, these regimens are not cheap. So cost per cure of tenofovir-based therapy was estimated to be almost $190,000 per SVR. And this was primarily related to the management of side effects, as you can see here. And as you also saw, that some of these regimens could lead to hospitalization. This is actually PRO data from tenofovir, and I was a part of that study. Again, as you see, not only now you have interferon, ribavirin with all its side effects, you've got tenofovir or boceprevir, and your PROs actually take another hit here, and they're not optimal. So now let's look at the same sort of data for second generation DAAs. And again, you saw the neutrino data for genotype 1 and genotype 4, and now we are getting to about 90% SVR rates. And when you get to the effectiveness from target for at least genotype 4, there is about 10% reduction in SVR, and as you saw for genotype 1, the reduction is probably about 15% reduction when you go, again, all related to the side effect of interferon and ribavirin primarily. This is a study I published about last year, a couple of years ago, looking at PROs and from neutrino. Now again, remember, this is not a randomized clinical trial. There was no placebo arm in neutrino. But again, because it has interferon and ribavirin, you actually have now again a decline in PROs that is reversible and comes back to the baseline, as you can see, but it does cause severe impairment of quality of life and work productivity. Cost per cure, again, here is another paper that we published with Sami Saab, that looking at the other interferon-based regimens, when you look at soft interferon and ribavirin, from neutrino, the cost per cure is lower. And primarily this has to do with the fact that you are providing these regimens in a shorter duration of time. So less side effect management and less coming to the physician offices. So efficacy of interferon-free regimens. Now let's look at genotype 1 patients. And here, this is sort of a summary slide of different regimens. You've seen the slides from ION 1, 2, and 3. Both Mark Zakowski showed this. And yesterday we looked at this also. So you're reaching response rates over 95%. When you look at 3D regimen from AbbVie, again, very high sustained virologic response rate. The Optimus data, which is soft SIM, gives you again 95% response rate. And then when you look at soft DCV, the combination therapy, again in these patients, you have over 95% sustained virologic response. How about effectiveness of these regimens? Again, when you look at TRIO, I'm a part of the TRIO registry, and as you can see that there is not that delta that you saw in the interferon era and interferon first generation era. That delta has shrunk now by quite a bit. So you have similar efficacy when you're looking at the effectiveness rate between clinical trial data and community data when you get to these regimens, where you look at TRIO data, or on the right, my right, you look at the target data for LDV soft with or without ribavirin. Again, you're getting over 95% sustained biologic response rates. How about genotype 4 in terms of efficacy of LDV soft? To the left is the French cohort of small number of patients, 44 patients, but treated with LDV soft. And as you can see here, response rate are quite high, over 90%. And in at least one subcohort is 100%. The problem, of course, is small number of patients, and we need to make sure that these are actually replicated in large clinical trial. To my right and in your left, or the other way around, the NIAID paper was just published in the Lancet Infectious Disease. Only 20 patients completed this study. 100% of those patients achieved SVR. In fact, they only had 7 patients with cirrhosis, and all of those patients achieved SVR, and this regimen was well tolerated. So other regimens that are interferon-free, and in fact, some of them are ribavirin-free. You saw this yesterday. Again, you're talking about at least the 12-week regimen of SimSoft having a sustained virologic response of 100%. When you go down to 8 weeks, you lose SVR in some group of patients, especially those that have more advanced fibrosis and those who are prior null responders. Now, how about effectiveness data in real world? This is again target data, and now we are looking at soft SIM. Now again, you have a bit of a reduction in SVR, but not as substantial as you would have seen it in the interferon era. This is basically now efficacy data on the 3D regimen, with or without ribavirin. As you can see, that in the sort of yellow bars, when you look at the efficacy rates are best when this regimen is delivered with ribavirin. So ribavirin-free regimen of 3D had 91% SVR, while the other regimens that contained ribavirin had SVR rates of 100%. Now, I also promised to show you PRO data, and I showed this yesterday for LDV soft. Again, when you take interferon out, when you take ribavirin out, you actually experience improvement of PRO during treatment, and you have substantial improvement of PRO after achieving sustained virologic response. This is the only study that has the data on PROs. I don't have data on SimSoft or AVI regimen that's not been fully published at this point. How about cost issues? This is a cost effectiveness study that we published last year, looking again at a number of different regimens. When you again look at the top sort of part of the slide, cost per cure in non-cirrhotics, and at the bottom is cirrhotics. This soft LDV regimen is cost effective. It has lowest cost per SVR than the other regimen. Again, it has to do with less side effect management, shorter duration of treatment. So cost per pill may be high, cost per SVR is lower. So to summarize interferon-free regimens have substantially higher efficacy rates than what we have ever seen, 95%, and Mark is absolutely correct that we are witnessing a revolution here with these new regimens. Effectiveness is high in the real world, and it's similar to the efficacy rates. And it's one of the reasons that I think that is the case is that there's substantially better side effect profile and PROs that improve. Now, going back to the interferon sort of side of things, even if there is no access to interferon-free regimen, it's not only the PROs that will affect the difference between efficacy and effectiveness. Remember the other component of adherence. One component is PRO. The other component is actually duration of the regimen. The longer the duration, the lower the adherence. The third is the complexity of the regimen. So if you have to do an IL-28B and you have to do assessment of resistance before, and then you do response-guided therapy in real world, that makes things much more complicated, and the take-up of that and the practices will be much lower. So as I showed, although cost per pill is high for these regimens, and these cost per pill in different regimens are actually falling because of competition, cost per SVR and cost per cure is actually pretty good. Nevertheless, I think because of budgetary constraints that we all face in our countries in different sort of categories, it is really important that we still negotiate and continue to pressure the pharmaceutical company as well as the insurance company where I came from, or the payers where we are, to make sure that these regimens are widely available. So let me just show you a couple of slides on upcoming pan-genotypic regimens. This is the Astral 1 data. Mark showed some of this. Now you've got pan-genotypic. You're getting to the response rate over 97%. This is only with 12 weeks of this interferon-free, ribavirin-free regimen with SOF and VAL. Now there is this is the Merck regimen. The Merck regimen without ribavirin had an SVR rate of 97% in treatment naive, but the best regimen for the treatment experience was actually with ribavirin. When you look at the new ABI regimen, again, genotype 1, 2, and 3 from three different presentations, you now have somewhere around 90, 95, 98% sustained virologic response. In fact, the lowest response here is with lower dose of one of the regimens that you see in genotype 3, which is the metabolic virus. I'm going to repeat myself. That's the most difficult virus now in 2016 to treat. This is what we will be looking at in the long run. So in the short run, these other regimens will become available. In the long run, we will get these triple combinations that will hit the virus from 3 different sort of mechanistic areas, as Mark alluded to. And this is at least some preliminary data looking at the Gilead's regimen of SOF, VEL, and GS9857. and they are given for 4 weeks, 6 weeks, and 8 weeks. And I'll just show you the data for 6 weeks, and I'll mention the data on 4 weeks. When you look at 8 weeks, you've got 93% sustained virologic response rate. When you go to 4 weeks, you lose SVR. SVR is 27%. So we know that we probably will get to a 6-week regimen in the near future, but probably with the regimens that are currently available, getting to 4 weeks would be more difficult. But there are regimens that have been presented by Dr. Lau that actually combines regimens with a form of response-guided therapy that you can actually predict response early on, and then you can actually can provide that regimen only for 4 weeks. This is not published yet or presented. SOVVEL from Astral 1 PRO data. When you don't have ribavirin, as you can see, again here, as you can see in the top left, which is the quality of life with SF-36, you've got the fatigue questionnaire, you've got CLD-QHCV, and then work productivity. In all these aspects, the PROs go up. The work productivity, which is at the bottom left of mine, that actually shows that it goes down. That actually means that work productivity has improved. So these regimens improve PROs. So what are the current recommendations by the US in EASL guidelines? For genotype 1 in the United States, interferon does not have a role, except that when you look at genotype 4 patients, there is an alternative that will allow interferon-based therapy, as you can see here for 12 weeks. But when you look at EASL, the EASL guideline was summarized by Dr. Colombo just a minute ago, that they are a little bit more lenient with interferon and allow that. But having spoken to a lot of my colleagues, there is tendency now to go more and more towards interferon-free regimens. So to summarize, evidence currently suggests that interferon-free is clearly superior in all aspects that we assess outcomes with, whether it's clinical, patient-reported, or cost per cure. Interferon-containing regimens may have a role where interferon is not acceptable or accessible, but will have low efficacy and low effectiveness and lots of side effects. And I actually also suggested other barriers to adherence, that is not only the side effects but other things. The future challenges is really to identify patients. I think we're listening and we're hearing this theme again and again, to identify patients, to link them to care, to improve access, to make treatment affordable in every country by instituting sort of national policies that takes into consideration the reality of that country. So what is going to be applicable to the United States or to Europe or to Egypt may not be applicable to Saudi Arabia, or what's actually applicable to Saudi Arabia may not work for another country. This is our challenge if we want to eradicate the virus. I think Mark was pretty optimistic to suggest that we could, or WHO is optimistic that we can really eradicate the virus by 70% by 2030. I think at least in my lifetime, we'll still have hepatitis C around. We just have to make sure that we treat most of these patients by getting them access to these really miraculous drugs that have been developed over the next 5 years. And that's my last slide. Thank you for your attention.